So I have the pleasure today of introducing our presenters. We're all on camera right now, but once I've done the introductions, we are going to turn our cameras off and we'll come back on at the end. But while we do introductions, we're just going to keep cameras on. So we have Dr. Jackie Kammerer, is an assistant professor at the University of Connecticut School Psychology Program. Her research interests are in psychological assessment and validity issues. Dr. Kammerer teaches courses in cognitive assessment, academic assessment, and educational tests and measures. She is a licensed psychologist and a nationally certified school psychologist. We have Dr. Emily Winter. Dr. Winter is a licensed psychologist in New York as well as Connecticut and a nationally certified school psychologist. She completed her specialist level training in school psychology at the Graduate School of Education and Human Development at Fairfield University and her PhD in educational psychology, specializing in school psychology at the University of Connecticut. Her current clinical practice includes supporting children, adolescents, and families to provide comprehensive psychoeducational assessment. And we have Dr. Brittany Dale. Dr. Dale is an assistant professor for the Department of Special Education at Ball State University and also works as a licensed psychologist conducting diagnostic evaluations for children and adolescents with various neurodevelopmental, mood, and anxiety disorders. During her postdoctoral fellowship, she gained extensive experience in the assessment and diagnosis of neurodevelopmental disorders, including autism. And her research interests include cognitive assessment for preschool children, assessment of autism throughout the lifespan, and supporting families with loved ones on the autism spectrum. And with that, I'm going to invite our presenters to turn their cameras off, and I'm going to pass you over to Dr. Dale. Thank you very much, and I'll be back at the end for Q&A.
Hello, thank you for that wonderful welcome, Shelley. Today, we are so happy for you to join us as we talk about our research and what we have done in the area of early childhood assessment. Jackie, you can go to the next slide. Throughout this webinar, we will discuss our research as it relates to the developmental profiles of autistic children and how those might differ from those with developmental delay in language disorders. We will look at the cognitive, motor, and language implications for children born less than 32 weeks gestation, so those children who are born premature. And we will also discuss the importance of tracking development of children who are born prematurely through the toddler years and beyond. Next slide. As we get into our research, we really want to start with the presentation of why is this information so important? Why do we look at tests and measurements and early childhood assessment? Next slide. Testing infants and toddlers is extremely important. With the increasing survival rates of premature children, we must have accurate tests and measures to assess the developmental milestones that might differ based on these medical complexities. We know that we can use our assessment data to help us plan for our interventions. We'll get into the next slide about how this relates to educational law, as the three of us presenting today are school psychologists, but we understand the importance of understanding present levels of performance so that we have an accurate baseline of where children are at as we develop our goals in our intervention plans. Additionally, many of these tests and measures are utilized to monitor and progress and growth and are used for program evaluation. So as I mentioned, school eligibility is really important to us as school psychologists. You may or may not be familiar with educational law, just depending on what type of setting you practice in. But Part C of the Individuals with Disabilities Education Act, the federal education law that we use to fund early intervention services, indicates that infants and toddlers can receive early intervention services if diagnosed with a physical or medical condition that could result in developmental delays, or they have exhibited developmental delays because they haven't met certain milestones or they fall at certain performance levels below the mean. These developmental areas align with the developmental areas that are assessed through developmental measures such as the Bayley-4. Physical development includes gross and fine motor development, cognitive development, communication development, such as receptive and expressive language, social, emotional, and adaptive development. And again, within the school population, transitioning from Part C, which services end at the child's third birthday, into the school setting, which a preschool could provide services for children ages 3 to 5. We see that the Bayley is a wonderful assessment tool that practitioners, school psychologists can use to assess skills at that very vital transition period.
Okay, so I'm going to jump in and talk a little bit about the Bayley. We're assuming that many of you are here because you're big fans of the Bayley, so we'll just give you a brief overview. The Bayley is one of the most popular assessments of child development. There are many uses for the Bayley-4, used in the early identification of developmental delays, for the monitoring of young children's longitudinal developmental progress, for the evaluation of intervention programs, for research purposes, and to compare the development of children with specific diagnoses to more neurotypically developing children. There are 5 main scales that measure multiple facets of development, including cognitive, which looks at visual preference, attention, memory, sensory motor, exploration, and manipulation and concept formation. There's language, which involves both the receptive and the expressive language subtests. Motor, which involves both the fine and gross motor subtests. The social emotional, which looks at communicating needs, self-regulation, and using emotional signals. And then finally, the adaptive behavior, which encompasses listening and understanding, taking care of oneself, talking, relating to others, and playing. And you can go to the next slide. And now we're going to talk a little bit more about our current research. So I'll hand it over to Brittany.
All right, thank you, Emily. We began our research with a desire to look at special populations. So this is the first article that we published using the standardization data from the Bayley-4. This looks at children with autism, developmental delay, and language impairment, and it's published in Psychology in the Schools. Next slide. One of my research interests is autism spectrum disorder. And we know through the literature that children with autism who participate in intervention at younger ages have better outcomes. With autism's prevalence rising, with current statistics being 1 in every 36 children, it is imperative for us to understand how young children with autism perform on various assessment tools. Again, we know that early intervention results in gains in many domains, specifically the language domain, adaptive skill domain, social communication domain, and net language domain. Looking at autism spectrum disorder in relation to other categories that fall under the clinical population's broad umbrella, is very important. We know, again, I talked earlier about special education law and how children ages 3 to 5 can receive services in a school setting. This picture here shows how many children, I believe the statistics come from the 2018-2019 school year, how many children are qualified in a preschool setting under each of these 13 categories that fall under special education law. The largest groups are autism, developmental delay, and language speech impairment. And we also know, given the characteristics of autism, young children with autism experience developmental delays, and which could include language delays. So I was very interested in looking at, can we potentially see differences in how these children perform based on their classification? And again, Pearson collected this data through their National Standardization Sampling Project, and individuals who were identified with these various categories were able to participate. Next slide. So our sample included 102 children aged 24 to 42 months. Now, we do know that the Bayley-4 can be administered to children younger than 24 months. However, none of the children in the autism sample were younger than 24 months. And if you're a practitioner that works in the autism assessment or just works at all with children with autism spectrum disorders, we can accurately identify autism around the age of 2 years old. Some research suggests 18 months old. But the age group of our sample was determined by who we had for the autism group. We then included children with developmental delay that matched that same age group. And then the problem specific to language, we termed the group, there were 2 specific clinical samples within the Pearson sample. One was called language delay, and one was identified as specific language impairment. We paired those 2 groups together and called that group problems specific to language. Next slide. Here, just so that you can familiarize yourself with the demographics of our sample. But overall, I just want to highlight that the gender that was described within the sample mirrors that of what we see with early diagnoses of autism spectrum disorder, being heavy male diagnostics. So, and as you look, children with DD followed a similar pattern with more males than females, but the language group was pretty well balanced in terms of males versus females. Next slide. So we looked at 5 Bayley-4 subtests: the cognitive, receptive language, the expressive language, fine motor, and gross motor subtests. We did not have the data for the adaptive skills or the social emotional scale, so we did not include those in our analyses. And if you're familiar with the structure of the Bayley-4, receptive language and expressive language go together for the communication domain. Fine and gross motor go together for the motor domain, but cognitive, there's only one subtest. So we looked at this from the subtest level. We conducted a MANOVA to determine group mean differences. And we also performed a logistic regression to determine if group membership could be predicted by subtest performance. Because as I stated earlier, I'm very interested to know, can we determine any differences in the way children perform that lead us to more evidence of which category we should place them in? So what did we find? We found that children with autism scored significantly lower on the cognitive subtest compared to those with developmental delay. It was not, however, significant for any of the 4 other subtests. So children with ASD scored lower on the cognitive. Children with ASD also showed more global delays compared to the language group. So group differences comparing ASD to language showed that they were significantly lower on all 5 subtests compared to the language group. Findings also showed that children with a developmental delay had poorer fine motor skills than those with the problem specific to language group. And I want to make a note of that. That is actually not surprising to me, just as I think about how developmental delay is conceptualized from a school standpoint. In educational law, you can qualify for the category that's labeled developmental delay if the child's performance across any of the areas of development are 1.5 to 2 standard deviations below the mean, and it varies by state. But it's a significant delay from the mean to qualify. So if you, as a child, had only language issues, the developmental delay group in this case was more likely to have those fine motor problems, which from a classification standpoint in a school setting, if I were to see multiple delays that went along with language, we would categorize as developmental delay. But if we only saw delays specific to language, they would receive that language impairment category. So that particular finding goes in line with what I have seen in school-based practice. Another interesting finding was that group membership could not be predicted by subtest performance. So overall, these young children, we weren't able to predict which group they belonged in just by their performance on the tests. So what might this mean for clinical or school practice? It is still very important for school psychologists and clinicians to understand how young children perform on these tests, especially those children who are coming for an assessment because of some referral question that suggests their skills aren't where they should be. For a child with autism, our findings showed that children with autism had more global impairment compared to other children in that language impairment group, and then more cognitive delay compared to the developmental delay group. And that finding is consistent with what we know about early childhood diagnoses of autism. The research suggests that the more severe the autism, the easier it is to diagnose. So I suspect that these 2- and 3-year-olds who were included in the clinical sample received an early diagnosis of autism because they had more functional impairment than perhaps a child with autism who's diagnosed later because they have less functional impairment early on. So I think our findings fall right in line with that the children with autism were more globally delayed, which might impact how early a child receives an autism diagnosis. Along those lines, If we're evaluating a child who does not yet have a diagnosis of autism, and maybe we suspect it, we might want to, if we're seeing those global delays in our scores, either do a targeted type of social evaluation, or we can look to the Bayley-4 itself. You may or may not be familiar with the autism, the ASD checklist that is provided in the technical manual on page 84. This checklist consists of receptive language items, expressive language items, and cognitive language item or cognitive items, excuse me. So if you are seeing some of those more global delays in a child that you're assessing, I would recommend going to the technical manual and looking at that autism checklist to ensure we rule it out, or in terms of ruling out, do we seek a more comprehensive assessment, or looking at that checklist to say, maybe this is some more evidence where we do have to pursue a more comprehensive assessment. And lastly, before I turn it over to Dr. Winter and our next study, as I stated earlier, it is very important to use these tools to help design targeted intervention. So regardless of the category of eligibility that you're looking at, if it's a school evaluation, regardless of the referral question from a clinical perspective, we want to use the information that we gather from our tests to develop targeted interventions for these young children. We should use their present levels of functioning to develop individualized goals that will help shape their intervention plans. So thank you very much for listening to my research. We were very excited about the results of this study, and I will go ahead and pass it over to Dr. Winter to talk about our next study.
Thank you. So our second study that the team worked on was published in Journal of Intelligence, and we specifically explored infants and toddlers who were born preterm. We were really interested in a couple of different factors, one being the degree of prematurity. So that is classifying how early a baby was born, and then looking at their performance across those three main domains that Dr. Dale just talked about, specifically the cognitive, the language, and the motor domains. You can go on to the next slide. Thanks. So first, let's just do a little background on prematurity. Prematurity or preterm birth is an issue impacting infants and families globally. Within the United States, we have seen marked improvements in prematurity rates. Nevertheless, differences among groups in the United States still exist and impact various communities. For instance, according to 2021 CDC data, there are disproportionalities in the impact of preterm birth, specifically on Black communities, as prematurity rates are 50% higher than babies born to white and Hispanic parents. When we think about mortality as well, prematurity continues to be of concern for the cause of death for newborn babies, as well as for our youngest infants. At the same time, we know that many, if not most babies, especially here in the United States, do survive to go on to live healthy and happy lives. This fact supports the idea that practitioners supporting older individuals, whether that be children or adolescents or even into adulthood, they may be interested in inquiring more about a client's birth history to understand some of their developmental challenge that they may have faced as a baby or an infant, and as a result to being born preterm. Okay, you can go on to the next slide. So a little more background. The literature on children born prematurely has continued to show that preterm babies outperform, that full-term babies outperform preterm babies by about 12 IQ points, even later on when they're tested into adolescence. And this advantage for full-term infants also extends to the language and motor domains as well in prior research. These are pretty grave discrepancies and persist, kind of showing those outcomes for preterm birth. And they highlight the importance of the access to high quality care and also notions of privilege of access to maternal and fetal health resources. These differences also may intimately connect to the fact that preterm birth accounts for 18% of deaths for children under the age of 5, as well as 35% of deaths of newborns under the age of 28 days. You can go on to the next slide, please. So here is a screenshot from our study of the demographic information, similar to how Dr. Dale provided. So we conducted our analyses, again, using data from Pearson's Bayley-4 special group studies in that norming sample. And one novel part of our study was the breakdown by group. We found that often in prior research, frequently there was the examination of preterm as a group as compared to a full-term control. We were really interested in this idea of degree of prematurity. So how premature a baby was born, to see if that impacted any of the findings. So we used 3 different groups. So we have full term, so any baby that was born over 37 weeks, extremely preterm, so babies who were born under 32 weeks, and moderately preterm, so babies who were born between 32 and 36 weeks. Preterm children were matched to full-term control children on several demographic variables. And here you can see the breakdown of children's age, sex, race, ethnicity, as well as their parents' education level, again, all collected by Pearson's excellent and robust normative sample. You can go on to the next slide. So just as Dr. Dale mentioned, Pearson kindly provided the special population study data from their norming sample for us to use. So we reviewed these data across 5 different subtests. Again, the cognitive, the motor, which included that gross and fine subtest, and the language, which included expressive and receptive language subtests. And for the research design, we used a Mancova to consider group mean differences between our 3 groups. So full term, extremely preterm, and moderately preterm, while controlling for age. You can go on to the next slide. So for our findings, we first found that full-term individuals scored much higher than extremely preterm samples across the subtests, so cognitive, gross, and fine motor subtests. These differences were most pronounced with the highest effect sizes for cognitive and motor subtests, with a significant but smaller effect on language across both the expressive and receptive scores. Next, we learned that full-term peers outscored their moderately preterm peers, but differences were much smaller as compared to the effects seen in the extremely preterm babies, with actually no significant difference found in the expressive communication domain. So next, we found that babies born with moderate prematurity tended to score higher than those born extremely preterm. Furthermore, the most pronounced effects of these differences were seen in the gross motor arena, followed by expressive, cognitive, and fine motor. Interestingly, no differences were seen here when comparing moderate preterm to extremely preterm on the receptive language domain. These findings highlighted this novel part of the research breaking out by the degree of prematurity, suggesting that the longer a baby is in the womb, the more opportunity there are for skills gained, at least on a group level. Okay. Finally, we were interested in understanding the impact of time, so comparing infants and toddlers. So to do this, we took both of our preterm groups and put them back together in one, and then split them based on age. So moderately, extremely preterm back together is one preterm group, and then we had one group that were infants, so ages 2 to 17 months, and then another group that were toddlers, so 18 to 42 months. And as you see in these figures, age did not appear to influence the full-term fine motor and cognitive subtest scores. That full-term children in both age groups performed similarly on these 2 subtests. However, the age of the premature children influence their scores on fine motor and cognitive subtests. Infants, for instance, had an average score of 80 on the cognitive subtest, while toddlers performed 14 points higher. The implication here, which requires verification, of course, suggests potentially that there is a cognitive growth occurring between infancy and toddlerhood. We also see here for fine motor that the fine motor findings highlight moderately higher scores, roughly 7 points, when tested as toddlers versus infants. And we didn't see these differences in the gross and expressive communication domains. You can go on to the next slide.
So I am going to talk about an additional Bayley study that we conducted. It's kind of a bonus study. I know it wasn't described in the description of this webinar, and that is because it is a very technical study that is really focused on the psychometrics of the test itself. So I don't think there is as many practical applied applications for the findings from the study, but we did want to highlight the findings that might be most interesting to people who are actually using the Bayley in practice. So for this study, we were testing measurement and structural invariance of the Bayley, and different than the other two studies that we just discussed. This used the full total standardization sample of over 1,700 kids from the Bayley. So I'm going to only very briefly cover these results that are the most applicable to practice. So measurement and variance is a very technical statistical procedure that is able to determine and examine whether a measure or test has any evidence of test bias against whatever sorts of groups are being compared. We, for our study, examined both gender invariance for boys and girls, and then we also examined age invariance. And as you can see, there are 4 age groups that we created. We're making these comparisons, and those groups were created based on groupings that had been used previously in a prior edition of the Bayley Technical Manual for Factor Structure Analyses, and also because these age groupings had similar sample sizes. So our positive result is that from all of the statistical tests, we found that the Bayley is not biased towards gender or age groups, which means in practice that the Bayley is functioning similarly for all these groups, for boys and girls, and then the 4 age groups that we compared. So that means that equivalent cognitive, language, and motor abilities are being measured across these groups, which is a great thing, meaning that practitioners and researchers both can make comparisons between these types of groups and use those kind of comparisons for decision making in a valid way. And then in addition to the measurement invariance, we tested something called structural invariance, which is not focused really on the test itself, but is getting kind of at the latent construct that we're measuring specifically. So in this study with the Bayley, that was examining the cognitive, the language, and the motor abilities to see if gender and age groups had the same degree of variability or the same width of the normal curve for their scores, whether the relationships between cognitive, language, and motor abilities, the strength of those relationships was the same across groups. And then we also looked at the latent mean scores on cognitive, language, and motor to see if those were significantly different across the groups. So the findings I've highlighted here are the ones where there were actual differences between the groups. The other places where there were no differences, I didn't include it on the slide. So we did find that girls, in comparisons to boys, their mean scores on the language, motor, and cognitive abilities were significantly higher, but those differences were very small and not even practically significant, such a small size for the cognitive abilities. Then for the age comparisons, we found more differences across the groups. We found that for older children, their language abilities were more variable. There's more variability in the extreme ends of kind of the normal curve than there were for the younger kids. And then we found for the youngest group of children that they had more variability in comparison to the older ones for their motor abilities. And then the last piece is that we did find differences across the age groups for the relationships between all of these abilities. And so for the oldest kids, we found that their cognitive and their language abilities were most strongly correlated among all of the possibilities. And then for the youngest kids, we found that their language and motor abilities were the most strongly related. So now we're going to shift from presenting all of our findings from these 3 studies and talk more about summarizing what we found and the practical implications. So I'll turn it over back to Dr.
As I said earlier, when I went over my study on ASD versus developmental delay and the language group differences, there are some practical implications that we can take from our literature. Next slide. Since the ASD group had more global delays, especially compared to the problems specific to language group, it suggests, as we know, children with ASD at a young age need intervention. We should intervene across all domains. Oftentimes, one of the wonderful benefits of the Bayley is that even when you have a child who has lower functional skills, you can get through an individualized measure because there's so many items that you involve the parent in, and they can give you perspective on whether the child does or does not have that skill yet. But if you were evaluating a young child and didn't have the opportunity to directly assess a skill area, I think our research really shows that when you have a young child that is diagnosed with ASD, we know that they have lower functional skills. So let's intervene across all areas and give them as much support as we can within the setting that we have. As I also noted, children with autism, the very young children, tend to be more delayed than children who qualify just as developmental delay. Now, that just happens to be particular to our research findings, but we do know, again, our interventions, our test scores, excuse me, are going to help drive those interventions. Next slide. So as we found out with our research, we cannot use test scores to aid in diagnosis or categorization. And I wasn't necessarily suggesting that tests and measures can be used that way or should be, but our tests can sometimes lead us to patterns that allow us to explore more characteristics and behaviors. But we do know that we don't want to use the Bayley-4 for a tool to categorize young children. We really are relying on our observation and clinical judgment skills to diagnose, especially ASD. We know that the best indicator of autism is a well-trained examiner who, through their comprehensive social and emotional history, can get at a diagnosis of autism above what any one test can determine for us. So just that reminder that we should always be using our clinical judgment and observation skills, especially in these early years when we want to provide an accurate diagnosis that could open the door to specific interventions. For example, if you do work in the world of autism, you may be familiar that applied behavior analysis therapy will not be covered by an insurance company without a diagnosis of autism. So we want to be conscious of the tests that we and the tools that we administer so that we can provide accurate assessment data across various domains for these young children. And lastly, as I stated, we use comprehensive developmental measures to help design our treatment plans. We want comprehensive goals that relate directly to the baseline data that we can obtain from a child. And we can use the Bayley-4 and the items and performance on particular tasks as our baseline data that helps inform our interventions. And as providers, practitioners, school psychologists, we can use the Bayley-4 to be comprehensive. We can administer all of the sections of the Bayley-4 to give the most comprehensive plan that also includes that caregiver perspective.
Okay, so I'm going to jump in here and talk about our next implication, which is advocacy. There is a push in the mental health field, especially within models advocating for social justice, to train not only scientist practitioners, but scientist practitioner advocates. With this evolving role, the present research invites providers to consider the public health perspective of infant and toddler development and early identification to facilitate swift referral to services, as Dr. Dale was mentioning. With these data from our study, is this call for advocacy and policy changes for increasing access to better access to high quality care and improving outcomes for children and infants. And in this realm may also be for the push for improved maternal and fetal health care access, education and healthcare for pregnancy, or more inclusion and identification of autism within research, especially early identification. Again, this also ties into our findings, which require verification, but the suggestion of the emerging importance of early intervention for young infants and toddlers who are born premature. You can go on to the next slide. Another practical implication, thinking about these findings mattering for all clinicians, regardless if they work exclusively with infants and toddlers. Given that many infants and toddlers who were premature now do survive and live on to live healthy, happy, productive lives, we have infants and toddlers who grew up and then may continue to have some vulnerabilities later on in life. Thus, as clinicians working with children, adolescents, or maybe even adults, this reminds us of the intentionality we should approach when doing comprehensive developmental interviews as we seek to understand the birth story and how prematurity status, access to early intervention may impact somebody's skill level now as a child, an adolescent, or an adult. This also pulls in a little bit about emerging research suggesting connections between profiles, such as emerging research that may suggest that prematurity status in connection to later developed ADHD. At the same time, there's this caveat that the scores we achieved in a young age will not account for every single issue or variation in later development. So it's really important, again, for us to know these data and also be aware of our own personal biases, such as diagnostic overshadowing. So our research suggests that cognitive abilities measured at a young age can predict about 40% of differences in the outcome, but that also doesn't tell the whole story. So that said, in partnership with doing really comprehensive evaluation, like using the Bayley, which is a phenomenal tool, similar to other measures, we should seek to collect other data, qualitative data, lived experience data, in order to recommend the appropriate level of intervention, thinking about somebody's genetics, access to resources, social factors, health factors, and the environment that we're designing the intervention. And I'll hand this back over to Dr. Dale.
Thank you, Dr. Winter. So in summary, we want to really encourage you to know your assessments, understand the validity behind each test measure, and understand that patterns and scores cannot be used to group children into categories. You can have confidence that the Bayley-4 has wonderful statistical properties, and you can be confident that your results can be used to determine current levels of performance and help drive those intervention goals. There are very few assessments that have that are these comprehensive developmental measures that can be used at a very young age. So the Bayley-4 is a wonderful tool that has updated norms that we can all use with great statistical properties to help us gain the best information about a child who may be referred either to a school or a clinical population. And at this time, we've presented the information on our research and would welcome questions.
Wonderful. Thank you, everybody. That was really interesting. I just invite all of our presenters to come off camera. We've had a few questions in. I'm going to take the liberty of just answering one myself, if I may, because it came in the chat and it wasn't in the Q&A. And there's just one person, because I happen to know the answer to this one, just one person asking about the adaptive behaviour scale and whether or not that provided age equivalence from age in months, if I'm remembering correctly. I made a note of it here. Yeah, does the adaptive behaviour scale give you a specific age in months? So for the person that asked that in the Q&A, yes, it does. I just wanted to take the opportunity to answer that here because I thought it was maybe useful for everybody else. There's one other in the Q&A, and that goes, it was relevant to your presentation, Dr. Dale, and it was going back to that slide with the 13 different categories on the background school setting slide, and they were just asking for clarification if that data was nationwide or if it was like state specific.
Yes, that particular slide had the nationwide data. If you go to the Office of Special Education Programs, their fast facts sheets, and it's the 3 to 5 year old group, you can toggle and switch the from the national representation to your specific state. And it is very interesting if you go state to state to see how that belly changes at the bottom. Some states identify autism spectrum disorder much more frequently than they use the developmental delay category. There is a state out there that doesn't even have the developmental delay category. So if you go again, it's the Office of Special Education Programs and the 3 to 5 years fast facts. You can see that national representation and then by state.
Wonderful. Thank you very much. Right. So I'm going to just sort of go through some of these questions, and if people have more, please just pop them in the Q&A. So the first one is, I think this is for Dr. Winter's, a question for Dr. Winter. Are you using the adjusted or chronological age for premature kids when comparing scores to full term? Apologise if you answered that already, but I think we're looking for clarification on that.
I actually might have Dr. Camera jump in on that one.
Oh, okay.
The data that we used was provided by Pearson, and so I think the only variables that were collected were related to chronological age. So that's how we were analyzing it.
All right, thank you very much. Thanks for that clarification. Next one, and I think this is for Dr. Dale. So was there I may be able to add something to this one if you're unable to answer. Was there control in place so as to not assume those children who are most delayed were identified as ASD rather than developmental delay? Because they are so delayed, some of those behaviours look like ASD but are consistent with developmental delay. Were there other measures or items related to ASD explored to determine appropriate diagnostic classification?
We were not given item level data. So we relied on Pearson to give us those classification categories. And we do know that the special groups did have secondary classifications, and we were using their primary classification as to what group they got put in.
Yeah, and I was just going to add on that the details can be found in the Bayley manual that sort of talks about the um, how we gather data on those classifications and what the criteria are. I can't remember them all off the top of my head either, but we do have we are quite strict on making sure those classifications are based on clinician, their full diagnostic categories. Basically, those children have met those requirements. So, but there is further information in the manual, so I thought I'd just add that in. Another one, and again, I think for Dr. Dale, when you say that children's cognitive and language abilities are strongly related, was that just for those with ASD or across the board with developmental delay as well, for example?
So our findings show that the differences between ASD and the developmental delay group showed up in the cognitive scale. But when you compare the ASD group to those who it was just determined to have a language delay or language impairment, then there were more global delays.
Excellent. Thank you very much. Okay.
And I was just going to jump in really quickly there. I also don't know if that question was maybe related to the third study that I very briefly touched on, because that's where I was kind of talking about the relationships between the cognitive, language and motor abilities. And that last study was only with the typically developing kids that are in the normative sample. So we don't have anything specific to kids with, there are no kids with disabilities in that sample, if that question was related to that.
Brilliant. Thanks for that clarification. Okay, so here's a practical one. I'm a preschool psychologist in Illinois, and when we evaluate students transitioning from early intervention, we conduct a transdisciplinary play-based assessment. Could we be using aspects from the Bayley-4 as part of this transition process?
Yeah, I'm currently consulting in one of our local school districts in the preschool, and we take a multidisciplinary approach to our assessments. And although we don't have, my school district doesn't own the Bayley, you could, as the school psychologist, administer the cognitive subtest. And then your speech and language pathologist in your setting could be the one who administers the language subtests. And then an occupational therapist and or physical therapist could do the fine and gross motor sections. Then you have the adaptive and the social emotional scales that the parent would be filling out in conjunction with some of the interviews that you would do. So I would definitely recommend that approach. If you have the ability to do a more interdisciplinary, transdisciplinary assessment to utilize the Bayley and each of your the staff that have those areas of expertise to take that section, and that allows for multiple observations of the child at the same behavioral standpoint and using the same tool. So I think it would be a wonderful approach.
Wonderful. That sort of answers the next question we had as well, which was, could a multidisciplinary team such as SLP, OT, Neuropsych use this assessment? So you've answered that one. Thank you very much. So a couple, I'm just going through. So yeah, I think, sorry, I'm just trying to work through which ones we've already answered. So there's some that I think may be better that, so for example, there's one, what brought the changes from 3 to 4? We're still using 3, but that might be better for one of us to answer on that question, I think. We do have some information on the website that gives summary of the changes from 3 to 4. And there's like a comparison document and things like that. So those, I think that's probably what better for a Pearson member of staff to respond to that one. The one that's in Bayley-4 suggests controlling prematurity when calculating age that is used to determine scores. Can perhaps Dr. Kamara clarify this with the response provided earlier. I don't know if you're able to answer that one or not.
We got the data from Pearson, so I don't have that specific details. If Pearson did some sort of transformation to transform from the chronological age to this adjusted age based on prematurity, unfortunately, I don't have that details. I don't remember seeing them in the manual, so that would be something we'd have to follow up to ask. It's a good point. I'm not quite sure. We did analyze the standard scores, so I don't know if that was part of their calculation of the scores before they gave them to us.
And I, to be fair, can't recall either without digging into it and having a look at that. There are details in the manual, which I would imagine that would probably be there, but I'd have to look to be sure. So, okay, another one. You say that the Bayley-4 can't be used to differentiate diagnoses such as ASD, language, and intellectual disability. Is that real? I mean, Bayley-4 is a relative, it's much older assessment. I don't know if anyone's able to comment on that or not. It's the older version of Bayley, so we're now on the 4th version. So no, okay, I'll skip that one. And maybe I'll get back to the attendee on that one. Which another one? Do you have plans for comparisons related to cultural or ethnic bias for ASD, developmental delay, and prematurity?
I know we did not look at cultural factors within our analyses, so we don't have plans actually to look at it further, either in ASD, developmental delay, or even our prematurity study.
Okay, wonderful, thank you. Then, are the scores based on the age controlling prematurity? If so, when prematurity is controlled for, premature children are still behind developmentally. Is that what you were saying? Does that, and again, I think that might come down to the details that we've got in the Bayley manual about those scores. So I'll kind of come back to that one. I think that's kind of it. There's a couple of questions I think we may need to get back to separately. I know somebody put in the chat again, and I'm just going to reiterate this one because I did, or they put it in the Q&A. It was just the question I answered at the beginning, which was, does the adaptive behaviour scale give you a specific age in months? In case you missed that, it does. So I did say that at the beginning, but you may have missed that question. I'm just going to make sure there's nothing else. No, I think we've got 2 minutes. So it's probably a good point to stop, I think, at that point and just say thank you to our presenters for today. I found it really interesting. There's a lot of information to share, and I urge you to go and read those studies if you want to find some further information. If we haven't responded to your question, my recommendation is to, in the survey that comes through at the end, you can resubmit your question in there, copy and paste it and resubmit in there, and we'll get back to you on it. I think a couple of them are more sort of related to technical stuff that's in the Bayley manual, so we'll get back to you separately. But on that, we have 1 minute, so I'm going to say thank you very much and bid you all a wonderful day. And thank you to our presenters. Okay, thanks. Bye-bye.
Thank you.